Hi everyone. When I sit in the gynecological OPD, I usually get a question normally from the attendants. Doctor, do I get cancer also like the relative? Usually it will be the son of the doctor or uncle of the aunt. Usually they are desperate to know is he at risk of getting cancer. Hello everyone, I am Dr. Tejas SV, consultant gynecologist and gyne-oncologist, laparoscopic and robotic surgeon. Today I am going to talk about hereditary gynecological cancer. What are the implications of this hereditary transmission? What are the preventive factors and prophylactic measures that can be taken after knowing the hereditary nature of these tumors? What are the myths and facts that commonly ponders the minds of the general public? So, hereditary gynecological cancers represent a small but highly impact subset of patients do get these hereditary gynecological cancers. There's something difference between hereditary and familial cancer. Usually the hereditary cancers have a genetic background that is transmitted from one generation to another generation, whereas familial cancers do occur more commonly than the general population in a particular family due to certain risk factors other than genetic transmission from one generation to another generation. This is the classical difference between hereditary and a familial cancer. Now, how much of the gynecological cancers are hereditary? Usually, the ovarian and endometrial cancer have a genetic background that can be transmitted through hereditary. Usually 5 to 10% of gynecological cancers are hereditary. Usually cervical cancer and vaginal cancer is usually transmitted through HPV virus infection and it is not hereditary. Only few subset of rare cancers, rare variety of the histology of cervical cancers carry genetic risk. So what is the incidence and epidemiology of these hereditary cancers? The ovarian cancers is known to be 15 to 20% hereditary, whereas in case of endometrial carcinomas, it is usually around 3 to 5%. The most common hereditary syndromes associated with the endometrial and ovarian cancers is the hereditary breast and ovarian cancer syndrome, then the Lynch syndrome. So, what is the mutation risk percentages and the lifetime risk of the cancers? So, the common mutations associated with hereditary breast ovarian cancer is the BRCA1 and the BRCA2 mutation. BRCA1 carries a lifetime ovarian cancer risk of around 39 to 46%, whereas lifetime breast cancer risk is around 65 to 80%. BRCA2 mutation, on the other hand, has ovarian cancer risk of 10 to 27% over the lifetime, whereas breast cancer is seen in 60 to 75% of the cases having the BRCA2 mutation. Coming to Lynch syndrome, that is the mismatch repair gene syndrome, is usually seen in the endometrial cancer, which is associated with colonic cancer as well. What is the lifetime risk of developing endometrial cancer? It depends upon the type of the mutation. A MLH1 mutation has a risk of up to 54%, whereas MSH2 has a 57% risk of developing endometrial cancer. MSH6 mutation has 49% risk and PMS2 has a risk of 26%. Then what about the ovarian cancer risk in this subset of patients of Lynch syndrome? It's up to 10 to 20% of these women can develop ovarian cancer over the lifetime carrying these mutations. Now the next question is, so what is the clinical takeaway? So when we see the percentages, we see that these are higher than the general population. For example, the overall chance of developing an ovarian cancer is around just only 1 to 1.4% in general population, whereas it may go up to 70% in case of these mutations. The now next question is, who should be tested for these genetic or the hereditary cancer syndromes? There are certain red flags which we have to look for when to decide for these people who are to be get tested. Now, these red flags is usually a presence of high-grade serous ovarian cancer. So all patients who have been diagnosed with high-grade serous ovarian cancer has to undergo for the genetic testing for hereditary cancer. In case this comes out to be positive, the further members of the family had to get tested. Then, onset of cancer at a young age in the family, or multiple members of the family having cancer. This precludes for a strong family history. Multiple primary cancers. So a patient, a member in the family may have a breast cancer and ovarian cancer, presence of a colorectal cancer or a pancreatic cancer, presence of endometrial cancer or the colon cancer. There are multiple cancer in the same family. This hints towards the presence of hereditary cancer in the family. And these are the high-risk patients or the group of members who don't have the cancer itself, who should undergo the genetic testing. So, I am going to ponder about the two main syndromes which has to be dealt with in hereditary gynecological cancers. One is the hereditary breast ovarian cancer syndrome, and another is the Lynch syndrome. Now, whenever the patient is going to for a testing, that is, those patients who are at high risk, multiple family members, and a diagnosed case of a cancer in a family member with history of genetic predisposition, these are the patients who has to undergo a proper pre-test genetic counseling. So this has to be done by a well-trained genetic counselor. So who gives what are the implications of these genetic mutations in the family members? What is the psychological effect that can happen? And what are the preventive or the prophylactic measures that can be taken in the family members or in the patient itself who has developed the cancer to prevent further development of the cancers in the patient or in the family members? Then we come to know what are the genetic testing modalities that is available. One is the availability of the germline testing that is usually done on the blood or the saliva. Next is the tumor testing or the NGS multi-gene panels, which is done on the tumor, which helps in detecting mutations that are predisposing for hereditary. However, the confirmatory test is only done by the germline testing, which is done on the blood or the saliva. Now, how to interpret these results is also very important in these cases. So, you may read a testing result that shows a pathogenic variant, which means the patient is at high cancer risk of developing a genetic background. Then this requires intervention. Then there may be a negative result which shows no pathogenic variant discovered. So the risk depends upon the family history and does not completely rule out a hereditary risk, which can be occupied by some other cancer risk. Now there may be something called as variant of uncertain significance, where we don't need to do an immediate action, but we have to reassess periodically to look for any other mutations that can come up. Next, the key principle is to always interpret the results in a clinical and family context. Now, what are the prophylactic measures that can be taken in these patients who have a genetic test coming out to be positive? So, I am going to talk about in these two syndromes only. So, for BRCA mutation carriers, we have risk reducing surgeries. One is for the ovarian cancer, another is for the breast cancer. What can be done in breast or cancer prevention is prophylactic bilateral mastectomy at an age where the index case, that is the person who has developed a cancer, Other family members who test out to be positive for the mutation can undergo risk-reducing mastectomy, which gives almost 100% risk reduction in the development of the breast cancer in these cases. This is usually done at an early age than in case where the patient has developed the cancer. Next is the risk-reducing salpingo-oophorectomy, which offers up to 90% risk reduction, where BRCA1 mutation carriers has to undergo breast risk reduction surgery in the age group of 35 to 40 years, whereas BRCA2 has to undergo in the age group of 40 to 45 years. So this also reduces the breast cancer risk when the patient undergoes the salpingo-oophorectomy. So now the other concept that is coming upon is the risk-reducing salpingectomy followed by delayed oophorectomy, where we are trying to preserve the ovarian hormonal function and going for a oophorectomy at a later age so that the quality of life of the woman is preserved. These early results of the randomized trials are giving a positive results where the patient can undergo oophorectomy at a later stage. However, it has to be validated and the results are still awaited. For Lynch syndrome, risk-reducing hysterectomy with bilateral salpingo-oophorectomy after childbearing is advised. Coming to the surveillance of these patients who are at high risk of developing cancer, there is no proven surveillance for these patients. However, there are multiple proposed algorithms where with CA125 ultrasound, transvaginal ultrasound, and even endometrial biopsies has been proposed. However, the studies done till now have not proven to be effective modalities. Then what are the additional strategies that can be done in these cases? One is the use of oral contraceptive pills that can prevent the ovarian cancer by nearly 40 to 50%. Then lifestyle modifications in these patients can help a lot in preventing the development of the cancers. Now I'm going to talk about certain myths and facts about these hereditary cancer syndromes. One of the common questions I receive is, if there is no family history, it cannot be hereditary. No, not at all. Up to 50% of the cases may not have any obvious family history at all. There may be no red flags at all. Still, these patients may have hereditary risk due to small families or paternal transmissions. Next is, genetic testing is only for cancer patients. No, not at all. Any relative or attendant of a patient who has developed cancer and has tested positive for the genetic hereditary disposition also is necessary for undergoing a genetic testing after a proper genetic counseling. Then a negative test does not means no cancer risk at all. No, not at all. So we are testing for a limited number of mutations or syndromes that are proven to have known to risk for cancer. Whereas there may be other genetic mutations known which we have not tested, or there may be many genes which we don't know which carries hereditary predisposition. So a negative result just signifies that this particular hereditary risk is ruled out in this particular patient, but it does not rule out the complete risk of developing any other cancers in the future. Then preventive surgery is too much for a patient. No, not at all. In a particular patient who are at high risk of developing cancer, it's always good to undergo preventive surgery, which helps in reducing the risk of cancer in the future. However, an average risk person need not undergo a preventive surgery in such scenarios. So finally, what I would like to tell is hereditary gynecological cancers provides a unique opportunity in gynecology to act before the cancer develops. So recognizing the risk, testing wisely, interpreting carefully, and preventing effectively is a good way of attacking the cancer and preventing it. Thank you.